we'll just wait while everybody comes into the webinar. Oh, great, we've got some participants joining us now. So I'll go through the attendee rules of engagement. This webinar is being recorded. No one can see that you're attending unless you would like to ask questions. So if you'd like anonymity during the question and answers, please tick the box to send anonymously before sending your questions. You may ask the question at any point during the presentations, but they'll be answered after all of the talks. If we don't get through your questions in the allocated time, which is 1 hour for this evening, 6 till 7, we will answer them via email after the session. So this evening's agenda, Dr. Victor Hulme from Aevitas Fertility Clinic will be talking about causes and warning signs of infertility. Kelly Loggenberg from Next Genetics is going to be talking to us about genetic testing as part of your reproductive journey. And Sue Bedford, a nutritional therapist, is going to be talking to us about Getting Fertility Fit, and she's going to be doing that via video. After that, we're going to be having a question and answer session. I'd like to give a thank you to our sponsors for this webinar, Next Genetics, for helping us to bring all of this information to the public via this webinar. Okay, so thank you for joining us on our 5th webinar for Reproductive Health Month, South Africa 2021. My name is Saskia Williams, and I'm the founding director and CEO of Aevitas. I'm proud to be bringing this Reproductive Health Month campaign and these webinars to you in association with the wonderfully talented ladies of House and Fertility Media, Lucia and Michelle, as well as the IVF Babel Africa team. We are bringing you webinars every Tuesday and Thursday evening throughout February, featuring local and international specialists and speakers. So who's up first tonight? Our first speaker is Dr. Victor Hulme. Dr. Hulme is a partner at Aevitas Fertility Clinic in the beautiful Cape. He will be talking to us about the warning signs and causes of infertility. I see you're ready to go already, Dr. Hulme. Thank you.
Yes, thank you. Thank you, Saskia, for this opportunity to speak about this important topic. And I thought, rather than speaking about the traditional causes of infertility, like sperm problems, egg problems, and tube problems, I would rather highlight some of the common problems that I see daily in our clinic. So I just want to go there. Let's go one more. So to emphasize again that infertility is a disease that affects 1 in 6 couples. So it's relatively common all over the world. And the definition is the failure to achieve a successful pregnancy after 12 months of unprotected intercourse, or in the case of single women, of exposure to sperm. And the question also that you must ask yourselves is, should you wait 12 months? There are certainly couples or women who should seek help earlier than 12 months. So the topics that I want to touch upon is the effect of age on fertility, the fertile window and some of the misconceptions of when exactly this so-called window of opportunity is. I want to mention something about endometriosis and the effect on egg reserve. And I want to talk about the disease of obesity and the lifestyle problem of smoking and the effect on reproduction. So it's interesting that one of the most important factors that determine the success of our treatment is the female age. And especially when women are older than 36, the Americans say, if a woman is older than 38, she has reached the end of a reproductive potential. In men, this is really from the age of 50 relevant. So just some statistics, because statistics is really the way for us to explain and to understand fertility issues. So your most fertile time was when you were in your 20s or even earlier. So 6% of women will not conceive when they reach the age of 30 unless they are helped by the medical profession. At 35 is 14%, and we know that older than 36, 1 in 3 couples, when the woman is older than 36, will need help from fertility specialists or fertility treatments. And 40% of women will be unable to conceive when they reach the age of 40. This graph I use daily, and I sometimes feel it should hang in all waiting rooms of doctors, that people can see the effect of age, because many people, even people with a medical background, sometimes are unaware of the effect of age on the success rate of IVF treatment. So here you can see the female age on the horizontal bar, and on the vertical bar you see the chances for a live birth, the percentage of live births. So when a woman reaches the age of 36, you can see how the success rate starts to drop, especially after the age of 38. If that same woman uses a donor egg, then the success rate is not affected. So this tells us it's not her body, it's not the uterus, it is mostly the age of the eggs that determine the success of IVF. And also what one can see on this graph is that if a woman freezes her eggs at the age of, for instance, 36, the success rate of those eggs will remain stable. So if she uses them when she's 44, the success rate will be that of a woman of 36. So she became her own egg donor. So I just wanted to raise awareness of the importance of considering that women should freeze their eggs in their 30s if they're not planning on having a baby soon. Some words about the window of opportunity, or the fertile window. So is this true or false? The frequent intercourse decreases sperm quality. New information tells us that fresh sperm is the best, especially if there are problems with parameters like the sperm concentration. Even the sperm morphology is improved with frequent ejaculation. The best pregnancy rate is achieved by daily or alternate days intercourse during the fertile window. So this is true. Ovulation kits do have a place, but especially for couples who do not have frequent intercourse. So it's interesting for women to know when she's ovulating, but it's really only for couples who do not have intercourse more than once a week. And just something, a sideline, is that sometimes we see men who are bodybuilders or use testosterone thinking that that may improve their sperm count. And in fact, testosterone will suppress sperm production. And these men often have no sperm. Fortunately, it's reversible when they stop using testosterone. So the fertile window is then illustrated by this graph. So day 0 is the day of ovulation. So we've stopped using the temperature method because the temperature shift will only occur once ovulation has occurred, and the egg can then only be fertilized for what we believe 24 hours. So most conception, the most fertile day is in fact 2 days before ovulation. And the fertile window in a woman with a regular 28-day cycle will then start once she stops menstruating, and usually for the next 6 days, including the day of ovulation. So the fertile window is, what I find, it's often earlier than what most people think. Some words about endometriosis. So endometriosis is a disease that affects 10 to 20% of women during the reproductive years. And of these women, up to 40% may have an endometriosis cyst that we call an endometrioma, or a popular word for it is a chocolate cyst because it's filled with old blood that look like chocolate. So up to 40% of these women may have an endometrioma. And the management of this endometrioma has changed quite a lot over recent years. In the past, doctors used to remove the whole cyst, but we know now that many normal eggs are removed that are present in the capsule or the wall of the cyst. So our surgery is much more conservative now. So if you are planning, if there is a plan to operate on you and endometriosis, especially an endometrioma, is suspected, consider getting a second opinion on when and how the surgery must be done. For instance, also a teenager where an endometrioma is diagnosed on ultrasound, one should try to delay surgery until she's planning on having children. And medical treatment may sometimes be enough to manage her pain symptoms. The way that we measure the effect of surgery or of any condition on your egg reserve is one of the ways is by measuring the blood value of anti-Müllerian hormone, or AMH, as we say. So anti-Müllerian hormone is produced by the cells that surround the egg. So the more eggs you have, the more of these cells, and the higher the AMH will be. Something that I want to emphasize is women may think that if they measure their AMH, it will tell them how fertile they are. But that's not the case. It will only tell them if they go for IVF, what kind of response they can expect in egg production. So to emphasize the point, if two women of the same age have different AMHs, as long as they are ovulating and menstruating regularly, and as long as their partner has a normal semen analysis, their chances of conceiving naturally will be exactly the same. It's only when they go for IVF that the one with the lower AMH will produce less eggs. So that is the role of AMH. It's measured in fertility clinics. It's not a practical test to do in a normal general practice. Some words about the disease of obesity. This is an article that was published in 2016 in Fertility and Sterility, one of the journals that we read, where it was emphasized that up to 50% of American women during their reproductive years are overweight or obese. Overweight means a body mass index of above 25 to 30, and obese is 30 and higher. And you can Google how to calculate your own BMI, or body mass index. Your body mass index will have an effect on your pregnancy outcome and also on the newborn. For instance, women who are obese tend to have large babies. There's a risk for diabetes in the babies, the incidence of hypertension, of antepartum and postpartum hemorrhage. There are many complications of obesity during pregnancy. But it's not only during pregnancy. Obese women who undergo IVF have a 10% lower live birth rate. Also, I'll show you a study just now about the effect of obesity on polycystic ovarian syndrome, or PCOS. During IVF, women who are overweight need more medication and they produce less eggs. Also, the egg quality may be impaired during IVF, and we see that with fertilization. And there's also a higher miscarriage rate if a woman or a partner is overweight or obese. There must be an effect on the uterus itself, because surrogates who have a body mass index, surrogates are women who carry a baby for somebody who cannot carry her own baby. So if the body mass index is above 35, the live birth rate is half that of women with a BMI of under 35. I sometimes feel uncomfortable during consultation when the spotlight is only on the woman. So here we turn the spotlight onto the male. This graph demonstrates the effect of the male weight on the outcome of IVF. The red bars represent the success rate of an IVF procedure. And you can see here, this is a normal male, normal body weight. overweight, BMI 25 to 30, BMI above 30, and BMI above 40. So the red bars show that the success rate goes down. So the clinical pregnancy rate goes down. Also, the live birth rate will, with that, decrease as a man gets heavier. And what is interesting is that the miscarriage rate will increase as a man gains weight. So what can one do? Is there hope? The aim is to lose 7% of your body weight. And it's really only through calorie restriction, regardless of the kind of diet you follow. At the end, according to the authors of that article that I showed you, calorie restriction is the key. There are lifestyle modification programs which usually have a better outcome if you do it with other people. And nowadays there are apps that you can use on your smartphone, like Noom. Some people are very enthusiastic, and in the New England Journal of Medicine, there was a significant improvement in weight loss in people who use this app called Noom. This is quite severe, as to restrict your calories, but the authors of this review says that if you can restrict your calories to 1,200 kilocalories per day for 6 months, most people will lose 10% of their body weight. This is a landmark study that was done by Clark and all, and they found that they had 67 women who did not menstruate because they did not ovulate due to PCOS. And they found that when these women lost 10 kilograms over 6 months, 90% of them ovulated and started menstruating. And 78% of these women conceived naturally without any medication, just by losing weight. They started to ovulate and they conceived, and the normal miscarriage rate in humans is about 15%. So unfortunately, some of them also had miscarriages, but this was a significant study for all of us to demonstrate the benefit of losing weight if you are not ovulating. Something else about smoking and infertility. So in the Western world, in some countries, fortunately, it seems that smoking is decreasing, but there are still many people who, male and female people who smoke, and it definitely limits the blood flow to the ovary in the sense that menopause occurs earlier. The AMH of a comparable group of women of the same age will be 44% lower. So the egg reserve significantly lower in women who smoke. So there are less eggs, and the eggs that are there are less easy to fertilize. There's a lower implantation rate, more miscarriages, and even more ectopic pregnancies. And in the man, all the parameters are affected by cigarette smoking, and it's dose dependent. An interesting fact that they quote in the article on smoking is that smokers require twice the number of IVF attempts compared to non-smokers in order to have a live birth. So I'm reaching the end of my talk. I wanted to emphasize the importance of female age and the urgency in which women should look at the cutoff times of 36 and 38, and especially 40 years old, and that women should consider egg freezing in their 30s. I wanted to warn about surgery for endometriosis and the effect on egg reserve, the epidemic of obesity in the Western world, and the effect of smoking on the success rate of IVF. What is needed with IVF treatment is resilience, and resilience means the ability to bounce back from disappointment. So I hope that you realize most people can today be helped with IVF, but it is a journey, it's a road. I hope it's an interesting road and also a successful road for you. Thank you.
Thank you, Dr. Hulme. That was a very interesting and very informative presentation. We really appreciate it. And there are some questions, and we'll get to them at the end. And if anybody's got any other questions they'd like to ask, please pop it into the Q&A section, and we'll go through them after all the talks. So our next speaker is Kelly Loggenberg. Kelly is a genetic counsellor at Next Genetics, and she'll be talking to us about how genetic testing can form part of your reproductive journey. Thank you, Kelly.
Okay. Hi, everybody. Thank you, Saskia, for having me here today to talk. So you have given me a topic that I could spend ages talking about. So what I'm going to try and do is talk about some of the genetic tests that are available along the reproductive pathway. My slides. There we go. Sorry. So what I'm going to do is I'm just going to give a quick overview of genetics, just so that I can sort of place the tests and how they work. And then we're going to talk through some of the different tests that are available. So the tests that I have listed here are by no means the only genetic tests that are available along this pathway. There are many others, but not all of these tests will be applicable to every couple. So it will depend on each couple's unique circumstances. But these are just some of the tests that I'll be talking about. So this gives you an overview. These are not all the tests, but just some of them. And this is just to highlight that these tests are done from preconception to pre-implantation testing. So that's for couples going through IVF. Some of the tests happen during a pregnancy, and some, sadly, if there's been a pregnancy loss. So to start with the genetics overview, just a bit of a biology refresher. So obviously, humans are made up of millions and millions of cells, and inside each and every cell, you find the nucleus that contains the chromosomes. Chromosomes are then further made up of DNA, which encode for our genes. We all have more than 20,000 different genes, which contain the building blocks for life, and they determine everything about us. So when we look at these tests that I'm going to be discussing, some of them will be looking at chromosomes, and some of them will be looking at the gene level. So if we move on to chromosomes, because quite a few of the tests are actually looking at chromosomes. So just to quickly recap on this. So in total, we typically have 46 chromosomes. They come in pairs that are numbered from 1 through to 22. And then the last pair determine whether you're male or female. Women typically having 2 X chromosomes and men an X and a Y chromosome. And generally you would inherit 1 copy of each pair of chromosomes from each parent. Okay, so to get into the testing, so the first test that is offered or can be offered to couples preconception, so couples who are planning a pregnancy. This can also be offered to couples during a pregnancy, but ideally carrier screening will be done when a couple is planning a pregnancy to determine whether they are carriers of any recessive genetic conditions. So on average, we all carry between 2 to 5 different recessive genetic conditions. And mostly we won't know about that because individuals who are carriers of genetic conditions are healthy and well for the most part and don't have any health concerns as a result of being a carrier. However, if 2 individuals, both partners in a couple, are carriers of a faulty gene for the same recessive genetic condition, there can then be a risk to a pregnancy. And if both parents are carriers of the same recessive disorder, there's a 1 in 4 risk to every pregnancy. And when we do this kind of testing, we can either look at the most common recessive conditions, or we can look at up to about 300 recessive genetic conditions. And approximately 2% of couples who go through this testing will be found to be carriers of the same recessive condition. So this is just to illustrate, just so that there's a visual to sort of see what recessive inheritance means. So you can see here in this image, both partners are carriers of an altered gene, and it's only when they are both passed on, so in 25% of pregnancies or 1 in 4, Will the condition be present? 50% chance that the pregnancy will be a carrier, so no health concerns, same as the parent. And then a 1 in 4, 25% risk of not being a carrier and not having the condition. So who should consider carrier screening? Any couple that's planning a pregnancy, but there are certain couples who may benefit from it a little more than others. So in families where there's a known history of a genetic condition, where they would like to clarify the risk to their own children, couples from population groups where there's known to be a higher prevalence of certain recessive conditions would benefit. Couples that are considering IVF with a donor may want to have the donor screened for certain recessive conditions. And then couples that are related to each other may also consider carrier screening. The benefits of knowing that that both partners are carriers of the same recessive genetic condition is that it helps couples to make informed decisions regarding their reproductive options. So they may want to consider using a donor. They may want to consider prenatal testing during a pregnancy. It may also be a case of considering testing embryos for a specific genetic condition. So we'll talk a little more about that later. And then it may also be a case of planning the appropriate management for a pregnancy or treatment following the delivery of a child that is known to then be at an increased risk of a recessive condition. Okay, so moving along to pre-implantation genetic testing. So this is testing of embryos that are created through IVF. So once the embryos have fertilized, they're allowed to develop, and at around day 5 or 6, some of the cells can be removed, and those cells can be tested to determine if the correct amount of chromosome material is present. So we call this testing pre-implantation genetic testing for aneuploidy, or PGT-A for short. And aneuploidy refers to the incorrect amount of chromosome material. And why is it important to detect? Because we know that embryos that don't have the correct amount of chromosome material may not implant. It may lead to an early pregnancy loss. We also know that the risk of aneuploidy is linked to the mother's age. So from around the age of 35, we see that there is a risk of an increase in the risk of chromosome abnormalities. Although we can see these chromosome abnormalities in women, in the embryos of women at any age, but the risk does start to significantly increase as women get a little older. So again, who should consider PGT-A? Any woman who is, or any patient who's having IVF may benefit, but particularly where women are of advanced maternal age, or couples that have experienced recurrent pregnancy losses may benefit. So we know that some of the benefits may include the reduced risk of miscarriage, and fertility doctors may have more confidence in transferring a single embryo. We know that transferring multiple embryos comes with its own risks. And in some cases, it may reduce the number of IVF cycles that are needed to achieve a pregnancy. Okay, so pre-implantation genetic testing for monogenic disorders, so that's always a bit of a mouthful, PGT-M. So it's often referred to as pre-implantation genetic diagnosis also, so those terms are referred to or used interchangeably. And this is where we test embryos that are created via IVF for a known genetic condition. So either if one of the parents are affected by a genetic condition and they would like to reduce the chance of passing that on to any children they may have, or in a situation where both partners are carriers of the same recessive condition, a couple may consider PGT-M. So it's important that couples understand that there are limitations to this testing, and it's a way to reduce the risk of passing on a condition. No test can give you a 100% guarantee, but it is something that can be considered to significantly reduce the risk of passing on a genetic condition. So really I've covered who should consider PGT-M. So you could consider it for recessive conditions where a parent is affected, or where women are carriers of X-linked conditions. And really the benefits then are to reduce the risk of passing on that condition. There are also some instances where couples may want to perform HLA matching if they have a child with a specific genetic condition that needs that would benefit from a sibling who could potentially be an HLA match. So I'm not going to spend too much time on this one. So this the next test is endometrial receptivity analysis, or ERA testing. So it's a test to be aware of that can be done in addition to your IVF treatment. And it's a test that is used to determine each patient's optimal window of implantation. So by transferring an embryo at the optimal time for that specific patient, it may lead to increased implantation rates and then in turn increased pregnancy rates. So any patient who's undergoing IVF can consider ERA testing, but it may be most beneficial for those patients that have experienced recurrent implantation failure. Okay. All right, so non-invasive prenatal testing. So this is moving on to testing that can be done during a pregnancy, so once a pregnancy has been achieved. So this is a test that is done from around 10 weeks of pregnancy. It's a simple blood test that's offered to the mother to screen for chromosome abnormalities. We know that during a pregnancy, there is DNA from the placenta that is circulating in the mother's blood. And by testing this DNA, we can clarify the risk of specific chromosome abnormalities being present. And like I said, this can be done from around 10 weeks. The test can screen for the most common chromosomal aneuploidies. So that would include things like, for example, Down syndrome or trisomy 21, trisomy 18, trisomy 13. So those are three of the most common chromosome problems that we can see during a pregnancy. NIPT can also screen for sex chromosome aneuploidy, so if there are extra or missing sex chromosomes. There are also some NIPT tests that are newer and that can screen all chromosomes. And then you also have the option in some cases to test for specific microdeletion syndromes. So that's when there are very small pieces of chromosomes that have gone missing that won't be picked, and those result in 5 very specific syndromes. And those won't necessarily be picked up on routine NIPT, looking for either whole chromosomes that are extra or missing. Okay. So any pregnant woman can consider NIPT to clarify the risk of chromosome abnormalities if they feel that information would be useful. But particularly as women get a little older, we know the risk of chromosome abnormalities do increase. So often NIPT is considered in women who are 35 or older. If there has been an increased risk first trimester serum screen, NIPT may be discussed, or if a ultrasound abnormality has been detected. The benefits of NIPT is that it's non-invasive, so there's no risk to the pregnancy. It's an early screening test, so it can be done from around 10 weeks of pregnancy, and it has a high specificity and sensitivity for the conditions that are tested. So it's a very accurate test, and perhaps more accurate than the first trimester serum screening test that is also offered. Okay, and then the last test that I'm going to discuss is the products of conception testing. So for women who have experienced a pregnancy loss, this is a test that can screen the products of conception for extra or missing chromosomes or large pieces of chromosomes that are extra or missing. So we know that up to about 50% of all early pregnancy losses are due to chromosome abnormalities. Most of these are sporadic with a very low recurrence risk. So having this kind of information can be very valuable to couples who would like to know what is the risk of this happening again, who would like to know why the pregnancy loss may have happened. So this test helps to give patients and doctors an answer after a loss to assist with reproductive counseling. So products of conception testing is something that can be considered by any couple who have suffered a pregnancy loss if they feel that that information would be valuable to them to know what the cause was of the pregnancy loss. It's particularly advised for couples who have suffered recurrent miscarriages, so more than 2 or 3 miscarriages. And the benefits of the testing is to have accurate recurrence risks in for a future pregnancy. It allows for doctors to focus their investigations, because if a pregnancy loss wasn't due to a chromosome abnormality, there may be other investigations that could be considered. One of the most important benefits I found of products of conception testing is the psychological and emotional benefit that couples experience in having an answer in terms of knowing why a loss may have occurred. So in conclusion, these are just some of the tests or genetic tests that are available along the reproductive pathway. They won't all be relevant to all couples, and your healthcare provider or a genetic counsellor can discuss each of these tests in much more detail if you feel that would be beneficial. And for couples that are planning a pregnancy, a consultation with a genetic counsellor may be very valuable to discuss the tests that are available and relevant based on each couple's unique circumstances. Genetic testing is definitely not a one-size-fits-all, and there are a number of things that need to be taken into consideration to determine which test is appropriate in what circumstances. So I realized that was a lot of information to cover in a short space of time. So I'm very happy to take any questions, or if you have any questions later on, you're also welcome to get in touch. Thank you very much for listening.
Thank you, Kelly. There are a couple of questions that we'll go through after the video. So thank you very much for that, all that interesting information. Okay, so our next speaker via video is Sue Bedford. Sue is a nutritional therapist with an interest in fertility. She's going to be joining us via video to talk about getting fertility fit. Now, if the video doesn't play well for you, it will be uploaded to our YouTube channel tomorrow. We had a little bit of technical incidents last webinar with the video, so we're going to try and make sure it plays properly this time. But if it doesn't, as I said, it will be uploaded to our YouTube channel tomorrow. Let's give this a bash.
Hello everybody, I hope you're well. I'm Sue Bedford. I'm a nutritional therapist with a special interest in fertility, women's health and general wellness. I have my own business called Sue Bedford Nutrition, and I'm also the nutritionist for IVF Babble, IVF Babble Africa, and also a new magazine called M Magazine, which looks at the menopause. So why do I do what I do? Well, basically, from an early age at school, my favourite subjects were always food and nutrition, biology and chemistry. I then went on and studied science at degree level, and I've always worked within science. When I started to experience difficulty with getting pregnant, I basically wanted to know more. And I've always been interested in the impact that certain nutrients have on the human body. So I decided to study a master's in nutritional therapy, and my advanced independent study looked at the effect of nutrition on fertility, specifically IVF. So I was then successful pregnancies, 3, and I think this was a combination of obviously a fantastic medical team, but also really getting my diet right and lifestyle right. So from then I just decided that I really wanted to help others to try and get the very best outcome for others too. Since gaining my Masters in 2012, I've successfully worked with numerous clients and continue to do so, something I very much enjoy. Also the co-editor of 2 books in the field of fertility, the first in which I authored 2 important chapters. And I'm the nutritionist for IVF Babble, IVF Babble Africa, and also a new magazine called M Magazine, which is all about the menopause and lifestyle, and it's going to be very exciting. So what does a nutritional therapy consultation involve? Well, to start with, we'd have a chat or an email, and I would be looking to find out which area it was that you wanted some help with, and obviously just to get to know you a little bit and your scenario. I then have a questionnaire that I would send to you that obviously asks various questions about what you're eating at the moment, your lifestyle, any medication you're on, to build up the general picture of where you're at. I would then analyse it, and I would come up with recommendations that we would chat about in our initial consultation, which would involve maybe changing your diet slightly, some meal plans, going through different nutrients that you may be deficient in and trying to include them first. And within your diet, supplementation may well be needed, but that would be after my analysis. We would then follow up a few weeks later and then see where we were at, and if you wanted to continue to follow up with further consultations, then we can arrange that too. In addition to nutrition, there are other lifestyle factors that can impact or have an impact on fertility, and these include stress, amount of sleep, amount of exercise. So as part of a nutritional therapy consultation, I take all of these into account and look at the person as a whole, and then anything that needs to be tweaked or modified, we can come up with a plan to do so. So a few general top tips to help with fertility. I work on an individual basis, so one size doesn't fit all when it comes to nutrition. So what I'm saying now is very general, but might give you a pointer in the right direction to get started. So first of all, the most important thing is to check out your gut. All health starts with the gut, and if you're not absorbing your nutrients correctly from your food that you eat, or if there is an allergy or an intolerance there, it needs to be checked out and rectified to make sure that you are able to absorb those nutrients for optimal health. As I say, all health starts in the gut, so that will then impact all the major systems in the body, including the reproductive system. Also, in your diet, you need to be having a check out that you are eating some prebiotic foods. These are foods that feed the healthy, good bacteria in your gut. There's lots of studies going on with gut health at the moment. I'm really interested in it. And some people may benefit from taking a probiotic supplement there too. My second general top tip in relation to fertility and nutrition is to make sure that you're drinking enough water. Many people are dehydrated without realising it, and on average our body is made up of 60% water. It varies in different organs, but all of our cells need water for chemical reactions to take place. And then when it comes to fertility, the sperm and egg cells require water too. So sperm cells require water to be able to swim correctly towards the egg cell, for instance. So try to make sure that you're drinking 6 to 8 glasses of clean fresh water a day. and obviously include plenty of fresh fruit and vegetables in your diet too, as these contain a good amount of water in them, but don't skip on the water. My third general top tip for fertility and nutrition is to check the amount of sugar, refined sugar, that you are consuming on a daily basis. Too much sugar impacts on hormones. All hormones are very, very finely tuned in the body. They have a knock-on effect on each other. So if one's knocked slightly out of sync, it will have an impact on other hormones. This is a whole area which I look into a lot with people regarding PCOS. So I'm not going to talk in depth about it now, but sugar does have or play a major part in fertility and nutrition. My fourth top tip is to enjoy a whole food, nutrient-dense diet, which would include plenty of fresh vegetables and fruit, so more vegetables than fruit, as fruit does contain some sugar, and we've just spoken about sugar. Some lean protein and some slow-release carbohydrate type foods like sweet potatoes, a good example, and oats there. Some 2 to 3 portions of oily fish, if you like fish, a week, and plenty of nuts, seeds, pulses, a nice variety, and perhaps a couple of portions of lean meat a week, up to, if you like meat. An example of this sort of a diet is a Mediterranean type diet, but obviously when I work with you or with people as on an individual basis, I tailor their meal plans to suit what they like and what they don't like, as well as trying to incorporate some of the main nutrients that are key for fertility within their dietary plans. So obviously there's some that are in common for male and female that help general health, and then there's some that are very specific to helping with egg and sperm health, and I explore those on an individual basis too. My fifth top tip is to ensure that you are a healthy weight pre-conception, as being a healthy weight, not overweight or underweight, will help to ensure a healthy pregnancy, and not just for the health of the child, but for your health too and beyond. Now, I work with numerous and have worked with numerous clients with PCOS, and also people that want to lose weight before undergoing fertility treatment, or having to lose some weight before they are allowed to go into have fertility treatment along that route. And so, yes, I'm very familiar with helping people with dietary plans and weight loss management. So there's a few of my top general tips in relation to nutrition and fertility. I work with people on an individual basis, so I look after their individual needs and produce personalised plans. So if this is something that you would be interested in, my contact details will be available in a minute on the end slide. And because it's Reproductive Health Month, I'm offering 10% off fertility nutrition packages with myself if they're booked during February. Also, this may be of interest to you. I have produced a course with IVF Babble and IVF Babble Africa, which will be available and released in the next couple of weeks, so watch this space. In the meantime, if you have any queries, please do feel free to email me and I will get back to you. And I really look forward to meeting and working with you. Take care.
Okay, great. So now it's question and answer time. Everybody's ready. I can see Dr. Hulme, we're going to start with you. Somebody wants you to touch on, oh my goodness, this pronunciation of these medical terms. This is why I could never be a medical doctor. Adenomyosis, is that right?
Yes, yes.
So they're just asking if you can touch on it. So I think a little bit about it.
Yeah, so what is adenomyosis? It's a condition. Endometriosis means that a woman bleeds outside the endometrium, outside the cavity of the uterus. Adenomyosis means that she's bleeding inside the muscle of the uterus. So it's a cause of an enlarged uterus. It's associated with bleeding problems, and also it may affect the implantation of the embryo. So the management can be surgical, but it is difficult surgery because it may often involve a large part of the muscle of the uterus. So one can cut it out. And what we also do is we suppress the adenomyosis in the same way that we suppress endometriosis before IVF.
Okay, perfect. Thank you. And then what is the effect of mumps in adulthood on male infertility or male fertility?
So it's an inflammation of the testis. It can occur when a man has mumps in the salival gland, and it can sometimes then lead to sterility, meaning azoospermia in the male. So we don't often see it, but we have seen it, but it's not a common condition in our clinic. There's not commonly a history of mumps when we see men. 1% of men do not have sperm in their semen. But mumps is a known condition, but not that common cause.
Okay, thank you, Dr. Hulme. And then, does ovulation decrease AMH? If so, roughly how long does the woman have to do IVF or egg freezing before it's too late and pregnancy cannot happen? I'm a 30-year-old with an AMH of 0.5 due to surgery.
Yeah, so ovulation does not, so if the question is really whether being on the contraceptive pill where ovulation is suppressed, whether that will help with AMH, no. The pill does not affect the AMH value. Women still lose eggs. So a 30-year-old with such a low egg reserve, the quality of her eggs will be good, but the number will be decreased if she undergoes IVF. But like I said before, as long as she's ovulating regularly, and as long as her anatomy, as long as her tubes are normal, functioning, and open, then she has the same chance of conceiving with her fertile partner than any other woman of her age. So I may be concerned about the risk of scarring in her pelvis, and also she should seriously consider freezing her eggs now if she's not planning on having a pregnancy soon.
Okay, thank you. And then there's a little bit of feedback. Dr. Hulme, not a question, but an amazing presentation. You answered all the questions I had with me. So that's a little bit of feedback for you. So thank you.
Thank you.
And then Kelly, somebody wants to know what it means when a doctor says they're genetically incompatible. The female's eggs were good and the man's sperm was good, but together they don't make good embryos. Is that something you can shed some light on?
So I don't think I can answer that question without a little more information. So whoever posted the question, you're welcome to share my contact details with them. I'd happily try and assist, but I need to just get a little more information about why that was said, really. I don't want to make any assumptions.
Perfect. Okay, so the person that asked that question, please email me, saskia@ifasa.co.za, and then I'll share it with Kelly and we can go from there. And then Kelly, does medical aid cover the product of conception testing?
In many cases it does. It obviously varies between medical aids and the specific plan, but that's something that we will look into on the patient's behalf, but often it is covered.
Okay, perfect. Dr. Hulme, another one for you. Me and my husband have been trying for years, 5 years to be exact. We've been to a fertility specialist in Stellenbosch. She said it's unexplained, and both me and my husband went for all the tests, and all the tests are normal. His assistant did pick something up that looked like a cyst, but when I asked the doctor about this, he said, no, it's nothing. Our only option apparently is IVF. Should I go for a second opinion or should I just go for the IVF?
With unexplained infertility of such a long duration, the recommended treatment is only to consider, if the tubes of everything, one to presume everything is normal, to do 2 or 3 cycles of insemination. And if that is not successful, IVF should be the next step. So I agree with that recommendation.
Perfect, thank you. And Dr. Hulme, what are the best or most recommended vitamins to take in order to enhance fertility?
There are no real vitamins that will enhance it. You know, all women who want to conceive should take folic acid just to help with the formation of the neural tube of the embryo, of the fetus. But as long as the healthy, balanced diet, there is no evidence that any vitamin will enhance fertility. We do check vitamin D, like December D. We check vitamin D levels. Maybe it's involved. It's a vitamin that's involved with many processes in the body. So I think that is one that one must just check that your levels are normal, especially in these days with the pandemic. Vitamin D seems to be important. That's the only one that I will mention.
Excellent, thank you. That's it for your questions. Kelly, one more for you. Can a chromosomal disorder due to my age cause an ectopic pregnancy? I had an ectopic pregnancy in 2019. I was 38 years old.
So I'm happy for Dr. Hulme to also comment on this one. We know that ectopic pregnancies can be caused by lots of different things. So hormonal factors, inflammation of fallopian tubes, endometriosis can play a role, but we do often see chromosome abnormalities if we do products of conception testing in ectopic pregnancies. And at the age of 38, the risk is perhaps slightly increased, but without having done any testing, I obviously can't say for certain what the cause was.
Okay. Dr. Hulme, anything to add?
Yeah, I could just emphasize when I read about the effect of even cigarette smoking, like Kelly said, it's multifactorial. Even cigarette smoking is associated with a higher risk for ectopic pregnancies.
Okay, thank you. And there's been one final question slipped in. We've got a little bit of time left. Secondary infertility seems to be cropping up more and more. What is this?
Is a question for me.
Yeah,
Yeah. Yeah. I think it's as the population gets older in the Western world, so many people have their first pregnancy. It's been shown that the age of first pregnancy is slowly increasing all over the Western world. So that will, of course, lead to more women planning a second baby once they've passed 36, like I said, where 1 in 3 couples will need help. So secondary infertility means that you've had a successful pregnancy and that you struggle with a second baby.
Thank you. And lastly, what is the risk of miscarriage at age 40, Dr. Hulme?
In general, 15% of clinical pregnancies end in a miscarriage, and at 40, it's double that of a woman who is 20. So it is at least 30% of clinical pregnancies will end in a miscarriage.
Sure.
Yeah, so it's really high. And if you are like, if you are 44, 45 years old, it's about 90% of pregnancies will end in a miscarriage if it is with your own eggs, not donor eggs, own eggs. Yeah. So it's something to do with the chromosomes. Kelly's department.
Yeah, so that's the only thing I was going to add,
yes,
is to say that many of those will be due to chromosome abnormalities, many of those miscarriages.
Mm.
Very interesting. Thank you. Thanks very much. That brings us to the end of our webinar, perfectly on time as well. So thank you to everyone for keeping to time. And thank you to everyone for joining us, this 5th webinar for Reproductive Health Month 2021. On Thursday, we're going to be online at 6 o'clock again, discussing assisted reproductive techniques and innovative embryology. So register at reproductivehealthmonth.co.za. Thank you, Dr. Hulme, and thank you to Kelly for giving of your time this evening and your expertise. We really, really do appreciate it. And keep well and keep safe.
Thank you.
Thanks. Bye.